So I'm going to talk about the latarjet procedure, which has become one of the standard procedure for an off-track lesion. So I'd like to begin with a line diagram, which shows that a young patient has the most likelihood of getting a recurrence of the shoulder. So this is the group of patients that we should be very cautious about, and so what is a recurrent shoulder dislocation? At least two anterior shoulder dislocation events should have occurred, only then we'll call it a recurrent shoulder dislocation. First time dislocators are altogether a different entity and has to be treated on a different path line. The patient demographics such as high demand person and contact athlete also should be taken in account when we decide upon the treatment options. So what happens in a recurrent shoulder dislocation? Basically, there are two lesions along which I am going to like leverage my whole talk. One is a Bankart lesion, which is found in around 100% of the cases, almost all of them, and the Hill-Sachs lesion, which is found in around 80% of the patients with recurrent shoulder dislocation. The extent can be different in different patients, but these are the two lesions that we found. What are the treatment options for recurrent shoulder dislocation? Basically, there are two treatment options. One is a bony option, the other one is a soft tissue option. The soft tissue surgery involves an arthroscopic or an open Bankart repair, which involves anterior capsular labral repair. That is, a capsule and labrum is repaired along with inferior capsular shift, which is an important part of it. The bony procedure that I am going to talk about is the latarjet procedure, which is basically a coracoid transfer. So latarjet surgery, when, how and why, that is what I am going to discuss in this short presentation. So when is very important. Decision should be taken before the incision. Decisions are more important than incisions. So the essential tool here is the glenoid bone loss. What the literature has shown that around 25% of glenoid bone loss will lead to increase in the chances of recurrence, plus the effectiveness of arthroscopic Bankart repair decreases. And we need to know the other lesion, which is the Hill-Sachs lesion, whether it is engaging or not. The concept of glenoid tract is very important here. There are two ways we can assess it. One is through a radiological, the other one is clinical. The first, I'll describe a clinical one in which we have to do an end range examination after arthroscopically after doing a Bankart. But this is a late stage, we are already committed, and after doing an arthroscope Bankart, I am a bit dicey to do a full range end range examination. So the glenoid tract concept is the most important concept here. It is basically the distance from the medial margin of the rotator cuff to the medial margin of the glenoid contact on the humerus. And what the studies has shown that 83% glenoid tract, glenoid width is necessary to prevent Hill-Sachs to stop from engaging. So a Hill-Sachs lesion that is medial to the 83% is known as an off-track lesion. This is going to engage. And a lesion that is lateral to that line is known as an on-track lesion, and that is not going to engage. So this becomes the radiological score, and then we have to come like clinically. Clinically, how can we distinguish? Then there is an instability severity index score, which takes account of age, the degree of sport participation, like whether he is participating in a competitive sport, contact sport, and the radiological feature. But a better score is a GTIMS, which has come into play, and it takes care of that on-track and off-track lesion. So any person who is having more than 6 of either GTIMS or instability score, he should become a candidate for a coracoid transfer patient. So this is how the treatment algorithm goes. We basically divide the lesion on the two bases. The glenoid bone loss, if it is less than 25% and it's an on-track lesion, that is 80, then arthroscopic Bankart repair is the gold standard of treatment. It will serve the purpose. Then an off-track lesion, then we can do a procedure that is known as remplissage. We can do a procedure which is known as remplissage, which is basically an infraspinatus stenodesis. It also helps to ameliorate the problem, but at a cost of decreasing the external rotation. Then if the glenoid bone loss is more than 25%, the letter J is a good surgery. If it is an off-track lesion, then letter J, we can even do a remplissage, or if it is a very big bone defect, then we can take an autologous distal tibial allograft. So this is how the decision is made. So what is the latarjet procedure? Latarjet procedure is basically a coracoid transfer procedure. It is most commonly performed surgery for glenoid bone loss. What it does, it increases the glenoid tract. It causes dynamic transfer due to conjoint tendon sling, and the acromioclavicular ligament can be used to repair the capsulolabral complex, producing more stability. So there are two kind of transfer that can be done. One is a classical and the other one is a congruent arc technique. Both have their advantages and disadvantages. We'll discuss it in our discussion. So the second thing, after making a decision, how I do it, like most of the time, the patient I take in supine position on a beach chair kind of a position with a bolster between the two scapulas so that the scapula fall down, and around a 4.5 centimeter incision is taken from the coracoid tip towards axilla. We go through a deltopectoral approach, and then we expose the deltoid and the pec major. We try to identify the cephalic vein and retract it laterally along with deltoid and the pec major medially. The conjoint tendon is exposed along with the fascia over it. Fascia is removed, the clavipectoral fascia is removed to expose the coracoid and the conjoint tendon. The coracoacromial and the coracohumeral ligaments are released around a centimeter from the lateral edge of the coracoid. And then the pec minor is released from the medial border. I hope that you are able to appreciate that. Pec minor is released from the medial border of the coracoid. Then we measure around 2.5 centimeter from the tip of the coracoid and mark it with a cautery. Then with the help of either an osteotome or a saw, we cut the coracoid just anterior to the coracoacromial ligament. We take a coracoidoid out and make a drill hole along about 2 centimeter apart. We tuck the coracoid just under the pec minor and expose the subscapularis and divide it at the junction of upper 2/3 and lower 1/3 and retract it to expose the capsule. We make a longitudinal incision over the anterior capsule to expose the joint and insert a fukuda or a blunt Homan can also do into the joint and rotate it externally. Anterior glenoid is exposed and freshened with the help of a curette or a K-wire. The prepared coracoid is put over the anterior surface of glenoid and fixed temporarily with the coracoid. We have to make sure that the coracoid never sits proud because it can lead to accelerated arthritic changes. And then after confirming the position, we fix the coracoid to the glenoid. And we can also suture the coracoacromial ligament with the anterior shoulder capsule, but it is not at all needed. So wound is closed in layer and there is no need to suture subscapularis and the sterile dressing is done. This is how I do the surgery. Why I do it? Because it has a lower failure rate, it has a higher return to sports, and it is a cost-effective surgery. So Bankart is the blue-eyed boy of all the arthroscopic company. He can always ask like, "Aaj mere paas paisa hai, building hai, tumhare paas kya hai?" So the latarjet can always say that it gives you stability, it has less recurrence rate, and it is more cost-effective. The take-home message here is latarjet surgery offers predictable results in patients with off-track lesions. It has lesser recurrence rate, it has no loss of external rotation, and it causes early return to sports. But at the same time, it will not address a concomitant slap tear or a rotator cuff tear that occurs. Thank you.